This BBRAUN activity will be based on the new concept for extracorporeal organ support. With Marco Ranieri, we have worked together in a consensus conference in Belgium about this, and the term has been then utilized several times and is becoming a classic. But also we have the pleasure to discuss the possibility to combine extracorporeal CO2 removal and CRRT with one of the most eminent experts in this field. So with no further ado, I will ask Marco Ranieri to present, and I remind you we have in total about 30 minutes, so we should try to stick to the time. Thank you.
Thank you very much. I'll try to be as short and as sweet as possible. Now, the concept that Claudio described to you before has a substantial clinical and pathophysiological reasonings behind. And this is a review article that Claudio published on the Blue Journal a number of years ago, where he presented the biological, the physiological, and the clinical basis for the concept of lung-kidney crosstalk in the presence of multiple organ failure. The concept is that the lung, when it's sick, because of a number of mechanisms, is able to influence directly or indirectly through the consequences of mechanical ventilation to influence kidney function, and vice versa, the kidney, through specific biological mechanism or even specific therapeutical and clinical mechanism, is able to influence the functioning of the lung. There are several data supporting this view. This is a study that we published many years ago, where we presented for the first time the implication in terms of inflammatory response of the so-called protective ventilatory strategy. At that time, we were used to ventilate the lung of patients with ARDS with a tidal volume of 10, 12 ml per kilogram, with the target of normalizing arterial blood gases. In this study, for the first time, one of the first, we tested that by reducing tidal volume, targeting a reduction of the mechanical stress applied to the lung, we could improve survival. And we demonstrated the improvement in survival. We demonstrated the attenuation of the inflammatory response. But the mechanism that we proposed was an effect on multiple organ failure. And the organs that were the most sensitive to the mechanical stress of mechanical ventilation was the kidney. And later on, again on JAMA, in this mixture of experimental and clinical study, we were able to confirm this view. Mechanical ventilation was able to activate a specific biological pathway, the pro-apoptotic pathway, that was responsible for the manifestation of acute kidney injury. When mechanical ventilation was decreased, when the amount of tidal volume was decreased, the amount of mechanical stress was reduced, the amount of pro-apoptotic signal was attenuated, the amount of kidney injury was attenuated. And because of these reasonings, we end up proposing a number of circuits that were able to combine renal replacement therapy and a tool such as CO2 removal that would allow to use very low tidal volume, very low amount of mechanical ventilation, indeed, very low mechanical stress. And the number of studies end up clarifying how it's important to allocate the oxygenator and the hemofilter. So we not just proposed the circuit, but we went into the details on how this circuit should be implemented and optimized. And because of all this, we end up with this preliminary study that, because of the statistical design, in a way try to approach a randomized control trial. We treated a number of patients with this combined renal and pulmonary support technique with an historical control that was matched using statistical tools. So in a way, we were able to simulate a randomized control trial. So in the control group, there was conventional mechanical ventilation and renal replacement therapy, because the patients entered the study if they had ARDS, needing mechanical ventilation, and acute kidney injury, needing renal replacement therapy. So the control group was conventional mechanical ventilation, conventional renal replacement therapy. Intervention was very low tidal volume, supported by CO2 removal during renal replacement therapy in a single circuit. And by doing so, we were able to demonstrate a number of things. From the biological standpoint, we were able to demonstrate the attenuation of the pro-apoptotic signal when renal replacement therapy was combined to CO2 removal along super protective ventilatory strategy. But most importantly, we were able to show a significant signal in terms of clinical outcome, in terms of percentage of creatine reduction changes, and in terms of days of need of renal replacement therapy. Now, following this study, we had several papers that were proposing these tools. And here I'm briefly reviewing some of them. Our chair participated and generated most of this study. But what I want to conclude with you is presenting this retrospective observational study that took place during the catastrophe that we had to deal a number of years ago, the COVID, and hopefully we will not deal anymore. This is a retrospective review of electronic records of patients enrolled in the clinical database collected in the period of the first wave, 2010-2021, 9 Italian hospitals. The inclusion criteria was relatively simple. COVID-19 associated mild to moderate ARDS that required invasive mechanical ventilation and renal replacement therapy because of acute kidney injury. The study selected those patients in whom conventional mechanical ventilation was not able to obtain the so-called saved mechanical parameters for mechanical stress, so plateau pressure lower than 30, delta P lower than 15. So those that were exposed to what we call ventilator-induced lung injury were included into the study. They were included into the study because the clinician said, this guy needs renal replacement therapy. I cannot ventilate with conventional settings. Let me use this device that allows me to treat the kidney, but at the same time, allow me to remove carbon dioxide and use a super low tidal volume. So the renal replacement therapy machine was set at 300 ml per minute, sweep gas was set at 0 liter per minute, and tidal volume was progressively reduced down to 4. Our standard nowadays is 6 to 8. Once the lowest tidal volume was obtained, CO2 removal was initiated, activating the gas flow through the oxygenator in the circuit in order to maintain the same PCO2. And then PEEP and FiO2 were titrated in order to maintain oxygenation. This is the circuit that was used in our sponsor today piece of equipment. The study endpoints were two: feasibility and safety. Feasibility was achieve and maintain the super protective ventilatory strategy. That means a tidal volume of 4 and a plateau pressure lower than 25, maintaining a normal PCO2 and a normal pH. At the same time, we had to provide a sufficient and effective renal replacement therapy. Safety was the occurrence of severe adverse events. We included 27 patients, and renal replacement therapy plus ECHO was initiated about between 10 and 20 days after ICU admissions, and was discontinued after 4 days for death in the 52% of cases, and for normalization of renal function in the remaining 13 patients. So here are the results in terms of feasibility. You can see that compared to time 0, we were able to reduce tidal volume from 6 to 8 down to 4, decrease plateau pressure, and decrease delta P in all the patients. This took place maintaining a relatively stable PCO2 and pH. Now let me take a step back for nephrology from an intensivist to a nephrologist. If you ventilate a patient with a tidal volume of 6, you generate a minute ventilation able to determine a PCO2 of 40. If you go down to tidal volume from 6 to 4, minute ventilation will be 50% less, PCO2 will be double. And the double of the PCO2 will imply a much lower pH. That's why we need renal replacement therapy in order to achieve the super protective ventilatory settings. And we were able to do so. And this took place providing an effective renal replacement therapy. So the combination of the circuit did not impair the efficacy of renal replacement therapy. In terms of safety, we did not observe any major patient-related side effect, bleeding, clotting, or others. We had 4 episodes of premature circuit clotting that required circuit replacement. So, can we conclude that there is a systematic indication for this technique in the context of patients with ARDS in whom it's not possible to apply conventional ventilatory settings? We can say that putting all the pieces together, this treatment is feasible and is relatively safe. We cannot say that we have data that can tell you tomorrow go and treat systematically this patient. We still study because as Immanuel Kant was used to say, everything that is ethically accepted is available for everybody. Now, this technique is not available to everybody because we don't have the evidence. So we have to generate the evidence in order to be ethical today. Thank you very much.
Thank you very much. Immanuel Kant was famous to be very punctual, and you were very punctual as Immanuel Kant. So don't go away, stay here, because you have to then accept the discussion. They used to say that in Königsberg, they set the watch according to Immanuel Kant walking through the square. So please, we have now a clinical case and the demonstration that citrate anticoagulation can be done with the OMNI machine. And in light of this, we will have then some discussion, please.
Good afternoon, and thanks to the organizer for the invitation. I will start with a clinical case to show, to discuss later 3 main points which are, in my opinion, important in adsorption in sepsis. And these are the adsorption indication, the multiple and progressive organ support, and the anticoagulation management. I will go fast on the clinical case because we need time for discussion. So this was a case of a young woman, full-term pregnant, which developed a progressive respiratory distress due to COVID-19 bilateral pneumonia. She underwent an emergency cesarean delivery, and during surgery, her respiratory distress got progressively worse. She developed a severe hypoxemia, as you can see on the table on the right side. Her PF ratio was 60, and so she was referred to our center and was proposed for a VV ECMO. We went to this peripheral hospital and put a patient on ECMO using a jugular Avalon cannula and started the treatment. As you can see, here we have the ventilatory setting before and just after the treatment, and we could reduce the ventilatory pressures just in a very effective way. On day 3, the clinical conditions were still severe. Inotropes and vasopressure need was still high, and Maximus VIS score was 15. We faced elevated inflammatory markers, especially EL6 was very high, as you can see in the table. The patient presented oliguria despite furosemide infusion, and volemia was actually correct. We had to face positive fluid balances, and cholestasis appeared. So we took into consideration to start with a combined treatment, an hemoadsorption treatment with a Jeffron HA cartridge and a CVVHD treatment on the OMNI machine. We used an OMNI Plus circuit, which is an open circuit on which we combine the Jeffron cartridge, and we use citrate as anticoagulation strategy. We did perform three treatments, and every treatment lasted approximately 6 hours. We changed circuits, CRT circuits daily, and on day 5, the patient condition did improve. We could stop vasoactive drugs. We saw an EL6 decrease, a bilirubin decrease, and negative net fluid balances could be achieved. We also saw improvement in gas exchanges and also in chest X-ray, as you can see. So on day 5, we stopped absorption, and we held on with the CVVHD treatment because we weren't still available in controlling fluid balances. The further clinical course of this young lady was good. She had a slow and progressive improvement in gas exchanges, and on day 15 we could remove ECMO. This is the chest X-ray we took just before removing the VV ECMO. She was extubated on day 19, and 2 days later she could be discharged in pulmonology ward. So the first point I would like to discuss is indication to hemoadsorption in sepsis. We all know that sepsis is a very complex, syndrome. In which we could have an excessive immune response and a cytokine storm, leading to a local and systemic inflammatory response. What is important is that cytokine storm pertains to a minority of patients who exhibit a pathological response to stimulus. So what we have to do is try to measure inflammatory levels, inflammatory mediators levels in blood, and try to find individualized management rather than use a one-size-fits-all approach. So how CRT and adsorbers work in septic patients? Probably they determine a decrease in the peaks of cytokines and modify the cytokines and chemokine ratio from tissues to blood, positively impacting this leukocyte trafficking and this abnormal response of immune system. And what are the patients that could benefit more from this kind of treatments? Probably the most severely ill patients. The patients who develop hemodynamic instability, high SOFA score, high circulating cytokines levels, and disorders of coagulation. We don't have magic numbers in this kind of patient handling and no magic bullets in treatment. What we still know is that there is a lack of consensus on indication to treatment and in clinical practice guidelines. So in clinical research, we should try to identify what conditions should trigger hemoperfusion and for how long we should run with this kind of treatments. Machines now allow us to support organs in multiple and progressive ways. Failing organs share blood perfusion as a common target of our therapies. And we know that one organ failing can lead to other organs failing via organ crosstalk. In particular, kidney injury is very common, especially in COVID patients. Our group found was that in COVID-19 patients, kidney injury is very common, and also the RRT requirement is very common. We also found that acute kidney injury is associated with high ventilatory pressure, both plateau pressure and expiratory pressures, and also with positive fluid balances. So for treating the positive fluid balances of this young patient, we had two ways possible. Adding two different filters to the ECMO machine, the hemoperfusion filter and the dialysis filter, or try to use only one platform. We choose the second solution because it presents many advantages. We could choose the strategy of solute removal. We could achieve precise fluxes control. We could achieve precise net ultrafiltration control, and we can monitor pressure into the circuit. Last but not least, we could achieve a specific regional anticoagulation regimen. So in this patient, we started from highly positive cumulative fluid balances, and we were able to precisely titrate the net ultrafiltration, leading the patient to a full recovery. We held on the treatment until day 6 when the uresis was restored and we could stop CVVHD. The anticoagulation management is still a problem in these patients. The thrombotic endotheliopathy, which is typical of COVID-19 patients, presents two main clinical features, which are elevated fibrinogen levels and increased D-dimer levels. We also found that this kind of microthrombi are present in all organs and all tissues, and also in myocardial tissues, where they can cause syndromes which are myocarditis-like syndromes. We studied together with our cardiology colleagues the composition of this microthrombi in patients suffering from acute myocardial infarction and COVID-19 positive. And what we found was that these microthrombi were different in composition respect to the ones from COVID negative patients. So we can say that the COVID coagulopathy is quite peculiar, and we have to look for the use of tailored antithrombotic strategy to counteract these effects. So what did we do with this patient? We had two problems. On one side, we had an ECMO patient, which was in heparin, of course, and a prothrombotic patient, as we thought. So we had to start with the heparin infusion, and we had to keep heparin dosage as low as possible. On the other side, we had to anticoagulate the filter, and we decided, as we always do, we use the citrate to anticoagulate the filter. These are the fluxes for the patient weight that we used, and the calcium and citrate dosages we started from. So in conclusion, this is only a real-life case in which I think technology helped us to handle very complex clinical issues. I think that this case learned us the importance of considering the whole picture, the whole clinical picture, rather than single clinical parameters. And also, I think it learned us the importance of adopting a tailored approach to patients' needs and changing clinical conditions, which is typical of critically ill patients. Thank you very much for the attention.
So thank you very much. I have maybe a curious question, because you both presented the flexibility of this platform to perform echoes. It is indeed designed for this reason. I have to tell you, I had the pleasure to to know the grandfather of this machine, because it was a machine coming from California that we subsequently developed with some friends, and we evolved into OMNI machine. Now, you presented the combination of CRRT and hemoperfusion. You presented the combination of CRRT and extracorporeal CO2 removal. Is it imaginable, don't kill me, but is it imaginable in case it is needed to apply the three therapies at the same time?
It is imaginable. I don't know if it's feasible.
Is there a rational?
Absolutely yes. Short and sweet, yes. You remember, you quoted the round table we had 4 or 5 years ago.
Oh,
Probably more. I believe the most important contribution of that round table was that at the end, for the first time, I mean, and Jean-Louis Vincent, and this is a genius. I mean, the royal we, as the former, the ex-British Empire would say, we had in the same room nephrologist, cardiologist, cardiac surgeon, intensivist, pulmonologist, talking about extracorporeal support. And we end up with the idea that we have a patient that has multiple organ failure, that has conventional therapies that do not work. We know that the extracorporeal can be a route to apply advanced therapy. We have to try to start to put the pieces together. And I mean, the process started there, as you mentioned before. There is a rationale. We are accumulating biological mechanism, basic science studies supporting this, clinical studies. I believe we still lack a technological development. I know that there are somebody's trying to propose a platform that is able to provide at the same time renal replacement therapy, liver therapy, plasma exchange, blah, blah, blah. But they are very preliminary. I think we need a further effort in this way.
Well, I can tell you a little secret. We already tried in our lab, and the machine responds very well for one reason. Both the oxygenator and the decapnizator, as you prefer to call it, and the cartridge have a very limited pressure drop. So you're not increasing pressure after the blood pump to a tremendous level, even if you use a blood flow in the range of 350.
Yeah.
So it is feasible.
Which pump? Roller pump?
Yeah, a roller pump. Yes, a roller pump. When you go beyond 350, 400, then it's a problem and so on. But I think it is feasible from the dynamic of pressure inside the circuit. So we are approaching the idea of multiple organ support therapy, modifying the circuit, and possibly having a platform that can do everything in one single thing.
Let me know. Let me play with you.
Okay, we will play. One more thing. You mentioned about citrate anticoagulation. You mentioned about different approaches. How do you somehow diagnose the different needs for different anticoagulatory approach?
Well, so normally in ECMO patients, you could use the CRRT machine together with the ECMO circuit, and you can also think that you are already on heparin, so you don't need another anticoagulation. But I think that one thing is the ECMO circuit and the patient, and one thing is the circuit. So we prefer to anticoagulate the CRRT circuit, even if on ECMO, and separately anticoagulate the patient with heparin. So in our opinion, these are two different things, and they should go together and not one versus the other one.
But you can perfuse the hemoperfusion cartridges both for a pressure gradient that is created in the circuit, in the ECMO circuit, or you can create this with the machine.
In this case, we normally use attach the cartridge directly on the ECMO circuit if we don't need any renal replacement therapy, for example, and we use heparin as an anticoagulation strategy, of course.
Very good.
Yeah.